You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
We have an aging population taking more medications than ever before. On this podcast, I will interview experts in geriatric medicine to gain insight so we can provide optimal care to patients in their golden years. I'm your host, Dr. Tamara Ruggles, and this is the Geriatric Pharmacy Focus. Hello, and welcome back to the Geriatric Pharmacy Focus. I am your host, Dr. Tamara Ruggles, and with me today is the diabetes pharmacist, Dr. Diana Isaacs. She is a pharmacist at the Cleveland Clinic. She's a diabetes pharmacist, advocate, and speaker. She is host of the Diabetes Dialogue podcast, which you definitely need to tune into. And she is passionate about the use of the latest technology to improve patient lives. So welcome, Diana. If you could tell us a bit about yourself and how you became the diabetes pharmacist.
Great. Well, thank you so much for having me today. So, gosh, I think it all started in pharmacy school when I was learning about diabetes from my amazing faculty and just immediately kind of fell in love with it. And then I was a part of APHA and the Operation Diabetes, and we would do these health fairs where even as a student with my limited knowledge, I felt like I could make such a difference doing glucose testing and providing education at these health fairs that I kind of knew I just really wanted to go that path. And so I did residency at the VA. And I obtained, my first position working as a VA pharmacist and in academia, and got my hours for the CDE, which is now a CDCES and all of that stuff. And then when I joined Cleveland Clinic, it's been about 9 years now. They were looking for someone that had, could do type 1 diabetes management. And prior to that, a lot of my working was in people with type 2 diabetes, especially within the VA. So I said, no problem. Let me learn. Immediately, there were opportunities to do a lot with CGM and insulin pumps. So I did everything I could to learn all about it, become a pump trainer, start CGM programs. And in doing it, I just realized I loved it. I mean, I think secretly I always loved it. I remember if there was always that person in class that had type 1 diabetes, had the insulin pump, and I was like, ooh, I want to see that. I want to learn more about it. But there just weren't so many opportunities until I came to Cleveland Clinic. And so now I'm so immersed in it and I love it so much. And I guess that's how I became me.
I love it. Yes. Follow your passion and you'll set the world on fire for sure. I feel that same way about geriatrics. That's how I felt about it in pharmacy school. I just fell in love with our older adults. And so it's awesome to see someone that's so passionate about it. So as we all know, the American Diabetes Association 2025 Standards of Diabetes Care has come out. And today we're going to focus more on type 2 diabetes because that's a majority of what we see in our older adults, especially in long-term care. And so when we talk about those ADA guidelines, what are our glycemic goals for our older adults?
Yeah, so we definitely have more relaxed goals for older adults. We worry about the risk of hypoglycemia, falls, and so we can be more lax. But I think it also depends on a lot of factors. So it depends how long someone's had diabetes, what medications they need to get to goal. If somebody is more newly diagnosed, despite being an older adult, we don't necessarily have to have a higher A1C goal versus someone that's had long-standing type 2 diabetes that likely has progressed to needing more medications and may be needing insulin. That's where we'll say, you know what, instead of needing to shoot for an A1C of less than 6.5 or 7%, let's go ahead and aim for closer to less than 8%. And if someone's more towards end of life, at that point, we may get rid of A1C goals. We may say, you know what, the priority is we don't want hypoglycemia. We don't want severe hyperglycemia because that can lead to dehydration and other complications as well. But it's not so important to be monitoring and getting to a specific A1C goal. I also just want to mention, being that I love technology and we have a lot more CGM use, that a corresponding goal with CGM is if we're aiming for that A1C of less than 7%, that's about 70% time in range between 70 and 180. If we are aiming for that higher A1C goal of less than 8%, that corresponds pretty well to 50% or more in that range.
Yeah, you bring up a good point about how important it is to avoid hypoglycemia in our older adults. And when we talk hypoglycemia, of course, the red flag is sulfonylureas. But also, I did want to ask, is there ever a time when sliding scale insulin is appropriate for our older adults?
So yes, so you bring up excellent points. Sulfonylureas have really, really fallen out of favor, even though they can be effective at glucose lowering. They are much less predictable, and if someone skips a meal, that can lead to hypoglycemia. In terms of sliding scale insulin, so we generally don't love sliding scale insulin because it's more of a reactive approach. So we'd prefer to have, if we need to use insulin, to have more set doses. But it is common that we may give someone a correction scale to use if they are requiring mealtime insulin and their glucose is above target going into their meal. We may give them a correction scale that says they can add a certain amount of insulin to their usual dose to help correct that high glucose level.
So it's okay if, like looking at one of my long-term care patients, let's say if they're on, 5 units with meals plus sliding scale, that wouldn't be as much of a problem to you as maybe just a person that's on a basal insulin plus a sliding scale Novolog or something like that.
Right. I mean, the thing is, if someone is needing to constantly add to their dose, then you want to evaluate, is something wrong with the dosing? Like, do we need to go up a little bit on the long acting insulin? Do we need to adjust the mealtime insulin at the previous meal? So it shouldn't be something that we need to rely so heavily on. But I think it's a nice tool to have in the toolbox because it could be somebody had an extra snack in between meals or is just running a little higher. And if you just give the usual dose, they're probably going to continue to run higher. Now, with these scales, there is the risk of uh, being used incorrectly, that it is requiring some extra math. So if someone is managing this on their own and having to add these numbers together, that can get confusing. There's more risk for errors, that someone could end up giving too much and then have hypoglycemia. So I think you've got to evaluate all of that and individualize. If you don't think it's going to be safe, that the person is going to just it's going to be too complicated, or the person's going to end up over calculating and giving too much. Or the other concern we worry a lot about is that people use these scales in between their meals. And generally, for someone on injections, even with rapid acting insulin, we advise to separate the doses by 4 hours or more, because we don't want stacking of insulin where, oh, they see they're high and they want to follow their scale and give so many units. But really, that insulin that they gave a couple hours ago is still working in the body. So that can be super dangerous. We see that happen, leading to hypoglycemia. So it's also, the person needs instructions of when to give it, and often giving it in alignment with the meals can be a safe way, because then usually it's going to be separated by 4 hours or more.
Yeah. Yeah. Okay. Well, that makes sense. So how about going back to the sulfonylureas? What would you do if, let's say, a 78-year-old patient in your nursing home was strictly managed on glipizide 5 daily and her A1C was 7.8? Do you look at the risk of that sulfonylurea and say, let's stop that and start something different? Or if they've been maintained on that, are you less likely to touch it?
So I think there's so many reasons to be on other medications. And unfortunately, there's a lot of clinical inertia where you see, okay, her A1C is under 8%. She's not having hypoglycemia, at least we don't think so. And let's just carry on. Now, this is where CGM can be very revealing too, because sometimes you think everything's fine, there's no hypoglycemia, but you put a CGM on someone and you discover there actually is some occurring during the day or overnight. Someone that's 78 could have other complications, certainly could benefit from the cardiovascular risk protection, the kidney protection, of GLP-1 agonists and SGLT2 inhibitors. So I really would be pushing to see if we could be using one of those agents instead. And I would prefer to use almost anything else that doesn't have the risk of hypoglycemia. And even if she's not having hypoglycemia now, a lot of things can change. What if her kidney function rapidly deteriorates and now that sulfonylurea is lasting in her system longer? So they make me so uncomfortable, especially in someone older. So yes, we need to change it.
Yeah, I agree with you completely. I leave a lot of notes for providers on the use of sulfonylureas and switching to something with a more of a benefit and then less risk. So I'm happy to hear that you agree with that, because some people
Awesome. Yes,
will.
we are in alignment.
Yes, because sometimes the providers will write on my notes and say, doing well, no hypoglycemia noted, continue, And so that's why I kind of wanted your argument or your perspective about it. So you talk about the GLP-1s and the SGLT2 inhibitors, and reading through the standards of care, the 2025 from the ADA, it does seem like the scales have shifted toward the GLP-1s and the SGLT2s, and maybe less favorable or not as much mentioned as like the DPP-4s and other medications. So can you just briefly summarize for people who haven't read the Standards of Care 2025 our treatment for type 2 diabetes?
Sure. So, yeah, I love the standards of care. I had like the great fortune of being on the committee that revises them back in 2020 to 2023. So I love them. I'm a geek with them. But essentially, the algorithm is separated into two major parts that I like to think about it. The first is you ask, does the person have kidney disease? Do they have heart failure? Do they have cardiovascular disease or high risk of cardiovascular disease? And if so, you want to use the therapy that is proven for that condition, irrespective of what the A1C level is, because those therapies will cause benefits. And those therapies are the GLP-1 agonists and the SGLT2 inhibitors. For heart failure, it's specifically SGLT2 inhibitors, unless the person has obesity and type 2 diabetes, in which case semaglutide showed benefit with HFpEF. Now, on the other side of the algorithm, if someone doesn't have those conditions, then we're really looking for one of two things. One is thinking about how much glucose lowering do we need and selecting an agent that will get us to that goal. And it lists out in a hierarchy of what are the most potent agents down to agents that may have a little bit less glucose lowering. So the GLP-1 agonists are our most potent agents, specifically the semaglutide, tirzepatide, the high-dose dulaglutide are called out. And then as you go further down, you get into like SGLT2 inhibitors have a little bit less, metformin's a little less, and DPP-4 inhibitors have a little bit less. Now, the other component of that is, does your patient need to lose weight and lower glucose? And actually 90% of people with diabetes have overweight or obesity. So often patients do benefit from both of those, in which case, again, the GLP-1s are highlighted, is specifically calling out tirzepatide and semaglutide. And then it goes down kind of choosing agents that still will have some weight loss, like the other GLP-1s, SGLT2 inhibitors have a little bit of weight loss. Metformin's more neutral, maybe a little tiny bit of weight loss. And then DPP-4 inhibitors are very neutral. And then you'd want to avoid agents that can cause weight gain, like sulfonylureas or insulin. Now, in the case of an older adult, you really got to evaluate. Maybe your older adult doesn't need to lose weight, right? Like maybe you're concerned that they're going to become too frail, in which case you might not want to use an agent that causes a lot of weight loss. And so the reason why DPP-4 inhibitors have fallen out of favor a little bit is because they don't have this positive cardiovascular outcome data that we have seen with the GLP-1 agonists and SGLT2 inhibitors. For the most part, they have been very neutral. There have been, like in some cases with saxagliptin and alogliptin, showing that there may be increased heart failure hospitalization. So that's obviously a little bit concerning with those specific two agents. So that's kind of why they've fallen out of favor. But that being said, if you only need a little bit of A1C lowering and you're looking for an agent that isn't going to cause weight loss and not have, so many expected side effects, there still can be a great reason to go ahead and use those agents. And then, oh, one other thing that I want to call out that is really new for 2025 is now looking at MASH. So looking at metabolic associated steatotic liver disease, that's been called out because we see that there's such a close link with that and type 2 diabetes. And so if someone has that, you'd want to go ahead and use agents that are protective, that will derive benefit. And so specifically, it calls out GLP-1 agonists, have some pretty good data around them. Also, SGLT2 inhibitors have a little bit of data, and pioglitazone specifically has shown benefit for that condition.
Yeah, pioglitazone's making a comeback. I feel like reading through the guidelines, I'm more and more liking pioglitazone lately after reading up a little bit. And it does state, for MASH or those at high risk for liver fibrosis, it says, how would we know if our patient is at high risk for liver fibrosis? Would you see an increase in those LFTs and that would kind of alert you to maybe we should look at this?
So it's a great question. So certainly, yes, if someone's liver function tests are elevated, that might clue you in for a referral. But there's actually another test that can be done that's called the FIB-4. And that's a really easy test to do. It's a calculation that incorporates the LFTs along with the platelet function as well. And it derives a score. And so if the score is elevated, then that prompts you that actually to do some imaging, to check to see if it's a fiber scan that they're supposed to do, which will determine basically if they have MASH or MASLD. And then that can guide you in terms of if they need a referral to GI.
Okay. Yeah, that's helpful. Reading about pioglitazone, and correct me if I'm wrong, is it one of the few agents we have that can actually decrease insulin resistance?
It is. So it does decrease insulin resistance. It does so in a more direct way versus other agents have a more indirect function in reducing insulin resistance. But yes, I've heard it described like exercise in a pill, because that's what exercise does. It basically makes the cells more sensitive to insulin and allows the glucose to be taken into these cells. So pioglitazone has that great benefit. And it's actually, it's taking the fat from the places we don't want the fat, like the liver, and putting the fat in the places that it should be. So that is a great mechanism. Now, it does typically cause some weight gain. So that's one of the reasons why it's a little bit, it may not be our first choice medication, but now that we're seeing all these other benefits, it is often a great kind of agent to use.
Yeah, and one thing, if patients are maybe hesitant to use it because of the weight gain, or even it got a bad rap, with heart failure, with the rosiglitazone. But I think one thing to think about is some of that weight gain from the fat redistribution from visceral to sub-Q? And if so, maybe that's not such a bad thing. I don't know. What are your thoughts on that?
Well, you're exactly right. Like it's not like weight gain associated with just eating more food. I think it's a healthier type of weight gain. And the thing is, not all weight is the same. So I think this is a much healthier type of weight gain. So that, it's a positive effect. It's just unfortunately, we're often looking at weight in such a simplistic way. We're just looking at the pounds on the scale. And so it can seem like it's a negative thing when actuality it can be a positive thing. There is also, though, there's some concern in people that have osteoporosis that there can be more bone fractures. So sometimes that's another limiting factor, especially for the older population, that we have to worry about. And then we don't want to use it in people with heart failure. So that's kind of another consideration. And you're absolutely right. Unfortunately, they got a very bad rap because of rosiglitazone. That was a meta-analysis by Steve Nissen, who's at the Cleveland Clinic, that showed there was increased rates of MI with use. And in the end, it kind of got debunked that it was, there may not have actually been increased MIs. But the really positive thing about all of this is that was really the impetus to say, okay, these diabetes drugs need to have cardiovascular outcome trials. We can't say, oh, just because it lowered A1C that it's good, because maybe it's not good if it's causing heart attacks. So it's really because of that that we now have all of this rich data with the GLP-1 agonists and the SGLT2 inhibitors. And we've learned that they're not just safe, but they're so beneficial for reducing these cardiovascular outcomes. And the other thing is, had we not done this, we might actually still be using DPP-4 inhibitors a whole lot more, because we also wouldn't know that those are neutral compared to the others. And with all the things being the same, like, I would want to use a drug that lowers the cardiovascular risk, right? But if we didn't have this data, we wouldn't have known that. And so that's some of the history and how it's led to where we are now.
Yeah, such a good point, because we have, like, I even think about lipid lowering medications. When you look at niacin, yeah, does it benefit nearly every aspect of the lipid panel? Absolutely. But is it going to lower your risk of major cardiovascular events? Well, probably not. So yeah, there's drugs on the market that will do what maybe you want it to do in lowering A1C. But if it's not going to give you long-term benefit, let's switch to something that will lower your A1C and give you long-term benefit. So
Right.
that new data is awesome.
Right. Yeah. And you bring such a blast from the past, because back when I used to work in the VA system, that was like when niacin was a thing. Like, we were using it. We were like, yeah, we're going to raise your HDL. We're going to lower your triglycerides. We'll add it to our statin. Like, it was big. We were putting everyone on it. And then now that we know it doesn't do anything to improve outcomes, it's really, and it causes flushing.
Yep.
It's really fallen out of favor.
Yes. Oh, I love clinical trials. So we have all this data. So, okay, so let's go through some scenarios. I wrote up some scenarios of older adults that is probably typical that we would see. And let's just talk through what might be appropriate, what might be A1C goals, et cetera. So first, this is someone I see often, and I'm really curious your opinion on this. So let's say we have Edward. He's 72-year-old male, and he has prediabetes. So his A1C has been teetering between 6.2 and 6.3 for a couple years now. He put a CGM on for 14 days, kind of saw what triggered his blood sugars, made some dietary changes, got his A1C down to maybe, 6.1, 6.0, but hasn't been able to get out of that pre-diabetes range. What do you do with this man? Do you start therapy to prevent, full-blown diabetes diagnosis, or do you just let him keep teetering along?
Well, does he have obesity also?
Let's say he could lose mild. Let's say he could lose 10 pounds, but nothing crazy.
Yeah. So if he has weight to lose, it sounds like if he only has 10 pounds to lose, then he may not qualify for needing to treat his weight. If he did, then I would say that could be a great approach to try to lower his weight. I don't know that we have to really do anything in this case other than continuing to reinforce healthy behavior changes. Yes, I mean, technically, metformin can be an option. We can use that for prediabetes, and that may help to delay the progression to type 2 diabetes. So I would bring it up through shared decision making, also taking a look at his kidney function, everything else, and see what he would like to do. The truth is, even having prediabetes is a cardiovascular risk factor. And so there could be some benefit to lowering it further. So I think that it really would be done through shared decision making, talking about some of these, benefits and risks. The truth is, if he had full blown type 2 diabetes, we'd be very happy with his A1C, right? So I don't know that we have to push it and say, we need to get you on metformin, or we need to put you on a GLP-1, right? But I think that it's good for him to know it's an option. And if he is really motivated and he wants to do that, we can. And metformin does not cause hypoglycemia. I would probably lean much heavily to metformin, because if he doesn't have a BMI over 30, I'm probably not going to even try. And probably we won't get the GLP-1 covered anyway.
But if his BMI was over 30, then a GLP-1 would be a good option.
Well, yeah, I think there's certainly benefit to losing weight, and that would likely, that's going to reduce his cardiovascular risk. That's going to get his A1C down, going to facilitate weight loss, which will have a lot of other benefits too. So absolutely, if his BMI was over 30, I would bring that up. It's just going to be the whole thing with coverage.
Sure. Okay, so that was Edward. Now let's talk about Betsy. Let's say Betsy's 78-year-old female. She has type 2 diabetes, hypertension, hyperlipidemia, and asthma. So she's got a few different comorbid conditions, but she's pretty active, and she was in her own home till she fell and broke her hip. Now she's just in a nursing home rehabbing and then hoping to go right back home. So what would her A1C goal be, and what do you think an appropriate treatment regimen would look like for her?
So definitely we can have a higher A1C goal because of her fall risk and everything. Although it still depends on the medications a person is taking. Because if, let's say, she's on like a GLP-1 and we can get her to a lower A1C and we can do that safely, I have no issue with it. But I would say I think an A1C goal of less than 8% would be completely fine, especially if she's needing insulin. Definitely. I think that that higher A1C goal is where we go. It's just that where where I struggle is when we set these higher A1C goals and we have patients that are on very minimal therapy. Like, let's say she's on just a DPP-4 inhibitor, or let's say she's on like 500 milligrams of metformin and she has normal kidney function. I mean, why do we have to say, oh, well, let's just get her A1C to 7.8, 7.9 and call it a day? So I think that's where we have to look and say, well, if we can safely do this, then like, why not do it? Like she could have an A1C of 6.5. If she doesn't need therapies that cause side effects and cause hypoglycemia, she can go lower than that. But I would say less than 8 would be the starting place.
Yeah, I like that mindset because, yeah, it's not like it would cause harm to probably go from a metformin ER dose of 500 to 1,000. If her kidney function's good, it might bring her A1C down a little more and prevent some macro or microvascular complications without causing her any harm. So I think
Exactly.
that's a good way of looking at it. Like, yeah, our goal is less than 8, but that doesn't mean we're not going to optimize medications.
Right. That's where I think we just really like have to individualize it.
Okay. I like that. Okay, so let's move on to the next person. Maybe we have okay, so let's talk about Robert. He's 85. He's got multiple complex disease states, type 2 diabetes, hypertension, hyperlipidemia, and Parkinson's disease. And he's a long-term stay in a nursing home, but he's not at the end of his life yet. So what would be a good A1C goal for him and then also a treatment plan? Is he kind of similar to the scenario before?
I think he's similar to the scenario before. I think probably a less than 8. It sounds like he's a little bit, perhaps a little bit more complex. So in his case, we may be, pretty satisfied with the closer to 8, but it's also, again, going to depend on the medications that he's taking and kind of individualizing it from there.
Yeah.
Yeah. The other thing I think about is like, yeah, if someone is not on medication or they're on very little medication, it's not like there's an A1C that's necessarily too low. Like the way I think about it is the people that are using GLP-1s for obesity and don't even have diabetes. Like think about how low their A1Cs get. Like we don't even routinely measure them really. So they can be very low, right? They can be in the 4s, they can be in the 5s. So a low A1C by itself isn't an issue. It just really depends on the medications a person needs to get there. And so I would make it a priority. I'm guessing with all these other comorbidities, he's probably taking a lot of other medications, right? And with the Parkinson's disease, he can be a higher fall risk. And so I don't think we need to be heroes and add all these drugs to get him to goal. So, that those are the things I would take into consideration on that.
So, do you think, let's say for these last two patients, their A1C is at 8, but we were able to safely optimize medications without a high risk down to an A1C of 7. Would a patient feel a difference as far as quality of life or how they feel? Do you think they would feel better and noticeably feel better from an 8 to a 7?
So in of itself, the 8 to a 7 Possibly not. But what the missing piece is the glucose variability. And that's the challenge with the A1C alone is it's based on an average. A 7 is an average of 154. But I need to know what's happening in between that average. And that is where CGM is also very helpful, even if a person's not wearing it all the time. To occasionally wear it prior to office visits can be very revealing because what we want to do is get rid of times of extreme hyperglycemia because then that can be symptomatic, right? That could be increased thirst and urination and fatigue. And we also don't want hypoglycemia. That can be falls that also can make a person not feel good. And also, people generally don't feel good when they're bouncing around and going from low to high and vice versa. So it's more about that. I think if they're having a lot of variability, they're going to feel that. With all things being equal, then no. I mean, someone's probably not going to really know the difference between a 7 and an 8 based on just how they're feeling. It's not until you get to glucose levels really high that people have symptoms. And sometimes they don't even have symptoms then because they get used to it. So it's more, I would say, about the long-term complications. And that's something that to think about as someone ages. What are we trying to prevent? If we're trying to prevent a cardiovascular event 10 years down the line and they may not have 10 years of life expectancy, then kind of what are we doing? Why do we need to get so aggressive with therapy? Even if it doesn't cause hypoglycemia, it still could affect other things, right? It still could affect electrolytes, like possibly kidney function, depending on the therapy. Like, so we still need to think about that too.
Yeah. So let's say our patients are progressing now to poor health toward end of life or even on hospice. At that point, what do we do for our patients with type 2 diabetes? And we know the A1C is no longer even a goal, right? It's to prevent hypoglycemia and symptomatic hyperglycemia.
Right.
But what would a treatment plan look like for these patients that are end of life, nearing end of life in poor health?
Yeah, so we're trying really to avoid extreme hyperglycemia, dehydration, and then we don't want any hypoglycemia either. So we're going to want to use agents, a little bit of medication to get to goal is needed, but definitely not too much. What it could look like, I mean, it could be a once a day long acting insulin just to get them down so they're not having hyperglycemia, but maybe we get rid of mealtime insulin if they needed that in the past because perhaps appetite's not as good and it's just, it's more risk than benefit. If someone is having wide fluctuations, we can add like a low dose or give a dose with the largest meal. But we kind of want the minimum to avoid these extreme complications, but we're not trying to get down, like we're not trying at this point to reduce that risk of micro or macrovascular complications. So there's not this drive to get A1C lower, not like a younger, healthier person.
Yeah, so maybe just a basal insulin to keep the levels low enough where they wouldn't have symptomatic hyperglycemia, but they also wouldn't have hypoglycemia.
Right. In this case, I'd actually consider, right, a long-acting insulin. And this is where you might even have just a very small correction scale for times where, let's say the person really had an excursion, they hit 3, they hit 400 or more, and that's not good. And you want to bring them down and you just give them a tiny bit of rapid acting insulin. So there does need to be some monitoring in this situation, whether it's BGM or CGM, but we need some kind of monitoring. And actually, there's many situations, especially like when people get to end stage renal disease, or anemias and different hemoglobinopathies where A1C is not even accurate. And it's actually very concerning when sometimes someone will have a falsely low A1C. And so the therapy is like backed off or nobody's monitoring. And like it turns out there's actually a lot of hyperglycemia. It's just the A1C was falsely low. So we need to be doing some kind of monitoring.
Yeah, that's a valid point because most of my patients have some type of anemia of chronic disease. They just had a surgery. I mean, there's few who have just like a perfect CBC. And so, yeah, that's a great point when monitoring that hemoglobin A1C if they are anemic.
If you don't have access to like CGM, Sometimes
Yeah.
like a fructosamine can be a secondary marker. I use it sometimes if the A1C is like just not kind of making sense matching up. It's just another metric. It's less, it's less validated, but it still can provide kind of a peek into what the average glucose is.
Great. That's a great tool for us to use. So when it comes to, since, CGMs in long-term care is a difficult situation because you can't bill Medicare for CGMs when they're in a nursing home. So what do your patients typically do? Do you have those families who just, sign and say, hey, I'll pay out of pocket for this CGM? Do you have nursing homes that are saying, hey, we see the benefit, so we'll pick up the cost for this? Or what do you see in your practice?
Yeah, so I see the families will sometimes they'll pay for it because they find that the benefit is really worth it. And depending on the CGM you get, I mean, the cost has come down a lot. And there's coupons like with GoodRx that you can get a better discount on it. So there are families that very much say this is worth it. Yes, there's a monthly cost to it, but we are going to go ahead and pay for it. And that way the person can have CGM and not have to poke themselves as much perhaps, but also be alerted for those highs and lows that can be happening in between meals and usual checks. So it is a huge, huge benefit. I guess we need to do some advocacy to get them covered in these situations, but certainly somebody on mealtime insulin, like I mean, to not have CGM is substandard care. Like it really is. Like it is the gold standard to have CGM. So we just we need to push for that to be available. But at the same time, also then the staff would need to be comfortable with using CGM and kind of troubleshooting the CGM as well, ideally.
Yeah, I agree. I hope there's a lot of advocacy and that CGMs will be covered for patients in nursing facilities by Medicare, because what an important thing for even preventing hypoglycemia. I mean, the huge difference this could make in our patients' lives and even for our facilities would be massive if we could just get them covered. So we'll definitely be advocating for that and pushing for that. So a couple of questions that I've thought of as we've been talking. SGLT2 inhibitors, our older adults can be frequent flyers when it comes to having urinary tract infections. At what point do you say, all right, we need to stop this SGLT2 inhibitor because the risk is greater than the benefit at this point?
Yeah, I mean, we can treat the UTIs, but yeah, at some point it's, you got to look at benefit versus risk. I would take into account the other comorbidities and what we're using it for. So if a person has heart failure, there's definitely a much stronger indication. Same with kidney disease as well. If we're just using it as a diabetes agent to lower glucose, then I'd say, all right, let's try to use a different agent. So I take all of that kind of into consideration. The other thing is people are more predisposed to UTIs when glucose levels are higher. So trying to work on can we get it down with adding another agent, with doing something else to prevent that risk. And then also just good hygiene habits can reduce that risk as well.
Very good. Okay, last question. When it comes to GLP-1s, this is purely anecdotal. This has not been published or any sort of the thing, but when I see the GLP-1s used in my nursing home patients, I do not see the weight loss that I see in the community. I don't know if you've seen this, but I'll have a patient start on semaglutide or whatever it might be, and their weight basically stays the same. Whereas in the community setting, if they were started on that and it was increased, they would lose massive amounts of weight and maybe even come off their insulin. I don't know, is it because, they're the food choices that they're offered, they don't have control over, they're sedentary. Have you seen this at all in your practice, or is it just me seeing it?
Well, that's really interesting. There's people that respond really well, and then there's people that don't respond as well. In general, people with type 2 diabetes don't have as much weight loss compared to people that are using it just to treat obesity. Additionally, we know that when it comes to the benefits, like the semaglutide and tirzepatide will have more weight loss than others. And it appears based on some data that tirzepatide, there's more weight loss with that. So sometimes some things we'll do if someone's not losing weight is we'll try to increase the dose, switch to a different one, switch to tirzepatide, and that can help. But I do suspect in this case that it is likely related to activity level, that they're just like, even if they're eating less, if they're not able to, if they're not getting up, they're not burning calories, they're not exercising, they're not strength training, that it's just going to be harder to lose weight. Like, yeah, there's probably a calorie deficit a little bit, but their metabolisms are probably also slowing. So it's going to be harder to lose that weight. So that's kind of my own hypothesis on that. But hopefully they're still at least usually they still derive the glucose benefit, even if there's not as much of that weight loss.
Right. Yeah. That's one thing I definitely monitor for is both weight and, blood glucose regulation. What are their sugars like? Have they improved even though the patient isn't, losing weight? So there's still benefit to being on the medication. But I do have a nursing home patient that was started on, I don't remember if it was tirzepatide or which one, but slowly I saw other medications being added on for constipation, right? So it was that, but then all of a sudden she's on Linzess, and then all of a sudden Reglan has started. And I'm thinking, boy, don't we stop this medication? What are your thoughts on that? Do you see that in our older adults? Because we already know they have decreased motility with aging. Are you seeing it become a problem in older adults?
Yes. So the GI effects of GLP-1s are no joke, and older adults seem to be much more prone to these effects. And while diarrhea gets a lot of attention, constipation is also a pretty big effect that can occur. Sometimes they both occur and they alternate, which is its own challenge. I think one of the things that contributes to it is definitely a lack of having enough fiber-rich foods and also water intake. And sometimes what happens is the people are eating less and then they're also drinking less, and they're not having enough fluids, and that can lead to dehydration, and that can also, worsen constipation. So yes, I think at some point we have to ask ourselves, if we are adding so many drugs so that someone can tolerate this drug, is it really worth it to continue that? Because all these other drugs can also have its own host of side effects. So it's really taking a step back. My perspective on it is, if I'm adding something in the beginning to get someone to tolerate when we're first starting the dose, or we're initially going up on it, like, I have no problem, giving a little bit of Zofran, for example, if someone's having nausea. But I don't want someone to need to continue all of these other medications forever. Like, that's not the goal. So I think we really need to reevaluate. Sometimes someone will tolerate one GLP better than another. So it could be, we try to reduce the dose, we try to switch to a different one. But yeah, I do not want someone to have to take all of these others. I'd rather, like, fiber. Let's have fiber rich foods, let's drink water and see how things go.
Okay, I like that. So maybe control the symptoms to start or when you're increasing the dose, but we don't want to have to use them long term. If we're needing them long term, consider switching to a different
Yes.
GLP-1. Okay,
Yes.
very helpful. Well, today's been amazing. I've learned so much, and I appreciate being able to ask you these questions and learn from you. And so if our listeners would like to continue learning from you, where can they find you?
Oh, yes, yes, yes. Well, you can find me on all social media. So I'm Diana M. Isaacs on X, on Instagram. You can just look me up on LinkedIn. But then I also have a podcast called Diabetes Dialogue: Technology, Therapeutics, and Real World Perspectives. I do this with my amazing friend and colleague, Natalie Bellini, who is a nurse practitioner, also in Cleveland with me, but at a different health system. And we kind of banter back and forth. And we talk about, like, the latest data, new studies that come out, things that have happened at professional meetings, new drug approvals for diabetes, or new technology. So you can check that out, I believe, wherever you get your podcasts. But also, if you want to see the video versions, it's at a website called hcplive.com. And you should see a link on there for Diabetes Dialogue.
Yes, everyone go check out her podcast because, like I was telling Diana before we started recording, I work with so many older adults and not a ton of them use CGMs. But I also still work part time in a community pharmacy. So to keep up, I have to listen. I not have to. I enjoy listening to Diana's podcast to stay abreast of the latest technology and treatment for our type 1s and our type 2s that are younger adults. So you do amazing work. Thank you for today. And everyone, go check out Diana and have an amazing rest of your day.
Great. Thank you.